Hello, my name is Jay Huang. I'm a junior attending in the United States. I go over cases almost on the daily from head to toe. If you're interested in that, consider giving a like and subscribe. Without further ado, thank you to Pathpresenter for this ovarian lesion. So what we see here on low power are areas of hypercellularity with regions of maybe hemorrhage, maybe necrosis. Let's go closer. So these are areas of necrosis where you see the cell remnants here, and adjacent to that are very pleomorphic cells, right? You have atypical mitotic figures with cells that are very hyperchromatic and pleomorphic. And you compare this cell to the lymphocyte, you see that the cells are very enlarged. And sometimes that can be hard to tell because all the tumor cells are large, so it's hard to get a baseline. So make sure to look for your reference cell. We see multiple mitotic figures in this single field of view. So this is very proliferative, and most likely that this tumor grew so rapidly that it outgrew its own blood supply, leading to necrosis. So here we see some fenestrations as well. And the most likely diagnosis, well, this is high-grade serous carcinoma of the ovary. And let's look more. So you'll have branching papillary patterns with slit-like fenestrations, marked cytologic atypia. This is a very great field of view to see how large these cells are with high NC ratios. These will be p53 mutant. This is important to know because high-grade serous carcinoma of the ovary is driven by p53 mutation. Normal p53 IHC is mosaic or patchy, and high-grade serous carcinoma, depending on what the mutation is, if it's a missense, if it's a premature stop, if it's a nonsense, you can have cytoplasmic expression, you can have null, and you can have overexpression. Your differentials include clear cell carcinoma of the ovary, but clear cell will often have some hobnailing features as well as eosinophilic secretions, which we don't see here. And then just to top it off, I'd like to go to Pathoutlines just to highlight the key points that Dr. Forgo and Dr. Longacre have done, and my apologies for mispronouncing the last name. But it's important to know that this is an epithelial carcinoma of serous cell lineage, and it can have papillary, glandular, and solid growth patterns. It's often bilateral and solid and cystic ovarian masses. So oftentimes when we think bilateral ovarian masses, we can think metastasis, but you should also think high-grade serous carcinoma. A certain subtype pattern that we should at least be aware of is the SET pattern, which is solid pseudoendometrioid and transitional cell carcinoma-like appearance. And the reason why it's good to know that is this appearance is more associated with BRCA1 mutations. The most important prognostic factor is stage. So let's look at this SET pattern. So this is solid pseudoendometrioid or transitional pattern. We see some here, and I would argue this ours that we saw is also of a SET pattern, and so this patient is more likely to have a BRCA1 mutation. So it's important to distinguish high-grade serous carcinoma of the ovary from low-grade serous carcinoma of the ovary. It's thought that low-grade serous carcinoma arises from the ovary itself and is driven by a KRAS mutation, whereas High-grade serous carcinoma is thought to arise from fimbriae, detached fimbriae that attaches to the ovary. It has a p53 mutation, right? So the precursor to high-grade serous carcinoma of the ovary is thought to be STIC, a serous tubal intraepithelial carcinoma, and these will often have prominent nucleoli, hyperchromaticity. And so when you look at salpingectomies, especially from BRCA patients, you can see potentially incipient STIC, whereas if it weren't removed over time, that would have developed into high-grade serous carcinoma. And you can see here how prominent the nucleoli is. And you shouldn't have any cilia. And then let's go over IHCs. So it'll stain PAX8. WT1 is very helpful to identify high-grade serous carcinoma of the ovary, as other ovarian cancers will not be positive for WT1. P16 is positive around 60% of the time. ER and PR can be positive. We talked about the aberrant P53, high Ki67 proliferation index as correlated histologically with the presence of a lot of mites. Negative stains will be CK20 and napsin-A. Napsin-A would be positive for a clear cell carcinoma of the ovary. So your differentials include low-grade serous carcinoma, but it will not be P53 driven. It won't have as much nuclear pleomorphism. Clear cell carcinoma, which we had talked about. Undifferentiated carcinoma, which is discohesive, often monomorphic cells, often decreased expressions of keratin and EMA. High-grade serous carcinoma, on the other hand, will be positive for CK7. Metastatic endometrioid serous carcinoma, usually WT1 negative or patchy. Endometrioid adenocarcinoma, this can be confused with the SET variant of high-grade serous carcinoma, but ERP are diffusely positive, WT1 variable, and P53 will be wild type. So I do want to mention, emphasize that high-grade serous carcinoma of the ovary, you have to differentiate it whether it's high grade or low grade. If you have serous carcinoma that develops in the endometrial cavity, you don't say high grade or low grade. Serous carcinoma of the endometrium is high grade by definition. Okay, so an ovarian tumor is shown. This particular pattern called solid pseudoendometrioid transitional is most commonly associated with, and it's BRCA1. What is the most important prognostic factor for overall survival of ovarian high-grade serous carcinoma? And that is stage. Well, I hope you enjoyed this video, and I will see y'all next time.